Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovations to train a new generation of health providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Cost of Care and the ABIM Foundation creating the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible innovations in teaching value at your institutions. The Teaching Value in Healthcare Learning Network has three major components: monthly webinars, discussion groups, and tools for educators, which is a space to share materials needed for dissemination of innovations shared through the network. I am Reshma Gupta, the director of the Learning Network, and I will be moderating today's webinar. We are honored to have Dr. Robin Clarke join us today. Dr. Clarke is an assistant professor of medicine and the medical director of quality of the UCLA Faculty Practice Group. A part of his role as health systems manager, he developed a program at UCLA to improve value by engaging frontline providers across all medical departments through provider-level dashboards and audit feedback and coaching. So Dr. Clarke, I'll let you take it away and help us understand a little bit about what you've been doing at UCLA.
Thank you, Reshma. Very nice introduction. UCLA story around care transformation began about 4 years ago. It was soon after I was hired into the role of Medical Director for Quality for our physician organization, the Faculty Practice Group. The intent at that time was to do as many systems are doing, which is to help shift us from the old paradigm of volume into the new world of value. And as an entity that organizes overall the physician organization, all of the clinical departments and specialties within the enterprise, the Faculty Practice Group aimed to lead that care transformation by supporting our clinical departments and specialties. And so I was charged, coming from a health services research training background, to try and help our clinical specialties into organizing themselves, building up their own infrastructure, engaging their own peers and colleagues in directing the work, and then to start to implement care redesign. I started at a time when we were just shifting to a enterprise installation of electronic medical record. There was a huge amount of transitions there. There were also big transitions as we moved from having a small number of lives under risk-based management through an HMO product that we were the delegated medical group for, shifting into taking on more risk through partnering with different health plans in ACO relationships. And at the time where the ACA was really going into effect, and our clinicians were starting to hear more about it, but for most of their clinical work were very, very directed just towards kind of individual clinical care. And so the thought was, how can we, at the system level, organize a scalable program that really answers how we felt you have to answer the question of where do we make changes in our practice that reduces waste in the system. So waste being those services that do not contribute to important outcomes that are meaningful for patients and for society. And so that kind of marching order came down to me to go out and support all the clinical specialties. And it started with a designation by each of the clinical departments across the enterprise, from ambulatory to tertiary quaternary care services, so from everyone from pathology to family medicine to neurosurgery to liver transplant, designated a member of the faculty from their clinical department to be a physician champion, a quality officer. And I went to them and started the conversation of, okay, well, how do we know where the opportunities are and how we're going to get you all to understand yourselves, understand your patients, and understand the opportunities. And the answers came back time and again that the existing data measures that were from PQRS or HEDIS-based measures were not as informative as they needed. So they didn't have detailed enough information to say, okay, well, here's where to focus. Those measures and those data systems also were very kind of honed in on just one part of the treatment episode. And so they didn't know, what was the give and take between providing that service at that point in time and something that may be a meaningful outcome, so 60 days, 120 days down the line. So thinking more along an episode base of care. They also, a lot of those measures did not incorporate cost data and shied away from it, really. And in particular, those data measures were not kind of structured in a way that really reflected the way that UCLA in particular and idiosyncratically delivered its care. And so the request that came to me from every one of the clinical specialties was, we'd love to get engaged with this, Robin. And we'd love to start moving with this. I'd love to start reaching out to my colleagues, but we don't have good information to start with. And unless we overcome that, that big data gap and kind of respect the questions that we ourselves are posing to ourselves about where our opportunities are, we won't be able to get started. And so the infrastructure that was necessary up front was, okay, well, how do you engage the right physician leaders to be able to pose those questions? And then how do you build up a scalable approach to managing the raw data that are in healthcare now, which are very rich, very targeted, but also very messy and are also very large numbers of data? And how do you manage all those to integrate them and to answer in a discrete way the questions that are being posed by clinicians? We were able to do that by layering in on top of our data warehouse, organizing data, and then going through an iterative process with our local clinicians from each of the clinical teams to be able to say, okay, well, what are the questions you guys are all posing to yourselves about the best ways to handle transitions to SNF care, or to reach out to patients with advanced cancer to address advanced care planning needs, to find those patients who are coming to the emergency department over and over again and develop care plans for them. And those were the opportunities and the waste that our faculty were identifying. And then we would develop at scale this ability to say, okay, well, let's actually put let's create these customized measures that are more meaningful to you, that are more relevant to UCLA practice patterns, and are more targeted for helping you unpack your waste and engage your colleagues. After getting those crucial pieces in place of the faculty champion, then having clear, meaningful information, those physicians then were the ambassadors who took those data points back to their colleagues and say, we're not, these aren't coming from outside. These are coming from within our teams here. These are questions that I posed. And look, I was able to get these really meaningful answers about discreetly about using clinical data to say, okay, this particular patient cohort at this particular decision point, did they receive an appropriate service, or did they receive a service that didn't provide much value when you look towards the episode-based measures of care? And those ingredients of good information, a physician champion, and then progressively going out and engaging the rest of the specialties led to a very rich infrastructure of team members and informed data-driven decision making that led us to be able to launch into dozens of improvement projects that were all data-driven across the enterprise. And then, even more importantly, to collaborative approaches within specialties that were more patient-centric in an organization, because you now had a robust kind of quality program and an engaged physician champion in radiology who was ready when the colorectal surgeons reached out about an opportunity in redesigning colorectal cancer CT use. And that overall rich environment just builds upon itself to have a very strong program for care redesign.
Great. Thank you so much for that great explanation. And, having been from Los Angeles myself, I was pretty blown away by the approach that you used, especially knowing the various webinars that we do have in the series, your effort to think about both at a systems level, what is true quality, what is true cost, what is actually something within the departments that's a meaningful change, and bridging that with the clinician leads in the various departments, so that they are bridges to creating that buy-in and to help move forward the culture change at the front line. One thing that I just want to highlight, which I think is so unique, is how broad and expansive the approach is. What struck me when you were talking is that you really sat down to create this very clear strategic plan across the health system to make sure that it's not just a piecemeal kind of effort within one department. This is expansive across the institution. And one question I wanted to ask you is actually how many of these, how many departments are you actually working with? And second is, how many projects are you aware of that are coming out of these efforts within the departments?
Across UCLA, the David Geffen School of Medicine, I think we have 39 clinical specialties. So the large departments, and then with the Department of Medicine and the Department of Surgery, have large divisions. And we have customized data dashboards for 38 of the 39 clinical specialties, and we've created about 2,500 custom measures for all of those dashboards. And what's exciting is that that's not just academic work, and it's really leading to, as you're questioning, improvement projects. And so there are using these types of kind of data-driven improvement science methods around 120 improvement projects across the enterprise, first ambulatory, transitions of care, inpatient.
And one question that I had is really getting for the listeners an understanding of what the culture was at the institution before you started. And then as this has been rolling out, how you feel that culture has potentially started to change, although knowing that it takes a decade to really change or longer.
Yeah, I would say that the culture at the start was one of, I think that is present in a lot of academic medical centers where extremely dedicated house staff and faculty, but in many ways it was the model of the martyr and the hero, where individual physicians rather than the systems of care were relied on to deliver the high quality product that UCLA was administering it. But it wasn't necessarily reliable systems. It was more someone staying very late or performing a heroic individual task. And that has really been, there's been tremendous executive leadership and organization across both the School of Medicine and UCLA Health side, tremendous investment in that over the last 5 to 10 years. And I think, with what people are hearing in their specialty societies, what they're reading about in the news, I think the ability to support that with a solid infrastructure locally has really led to a culture change of, we are doing this the right way, which is thinking about our patients, answering our own questions about where the opportunities are and testing change over the course of time.
Yeah, and I think one thing that strikes me when you're talking as well is that you have these liaisons in each department or division that in some ways are able to continue that discussion and the importance of these things within their own colleagues and within their own, cohorts through the hospital. And I think one thing that we often face in discussion is that frontline providers often have some hesitation in making these changes because sometimes the changes that are asked of them, they don't necessarily believe in those metrics. They don't necessarily believe that that is the most important thing, to create the quality for their patient or the cost saving. And I wanted to ask you if you could talk a little bit about how you chose those metrics or coached and worked with those division liaisons to choose them.
It does require a bit of a structure and a process to arrive at the kind of measuring and examining the right and potentially the lowest fruit opportunity, for instance. But it starts with kind of very structurally and systematically thinking about who the patients are that are cared for by that particular specialty, and dispensing with the kind of standardized data definitions, which usually don't provide enough kind of rich stratification of patients, but thinking through what can you use from the EMR to really very discreetly define particular cohorts require different protocols and different processes of care. But the identification of opportunities thereafter come pretty quickly. So one of the measures we did when we were engaging around red blood cell transfusion protocols was something that a lot of systems have undertaken. But and I can show you a slide here, looking at the top slide here, just the monthly number of units transfused using a statistical process control chart over the course of the last 2.5 years. The bottom measure is the one that is kind of developed by our hospitalists and blood bank pathologists, which is the percent of transfusion orders where 2+ units were ordered. And so this is one where this may not be an issue for all health systems, but this is one where our UCLA practitioners defined and identified and said, okay, you want to, there's in our culture and in our educational system here, there's this reflex to order 2 units from the beginning, where there's a lot of times where we should be ordering 1 unit and reevaluating. That's one where completely clinician-defined idea, and you can see that with the identification of that, implementation of an education program, sharing these data back with the specialties, having each of the quality officers from each specialty sharing data with their own specialty, that there was a dramatic improvement dramatic reduction in those kind of reflex 2-unit orders, and concomitant reduction in the overall number, amount of blood utilization at the hospital. So it's that kind of clinician-defined idea, which is not only likely to be richer in value in terms of because it's locally defined, but it's also one that is going to be better received by the actual in the trenches clinicians who need to change their practice patterns and stop ordering 2 units, 3 units, and then start doing 1 unit, getting a hemoglobin, rechecking, doing a 2nd unit if necessary.
Great. And I know there's a second slide kind of looking a little bit about at the dashboard that I think would be great to share as well.
Sure. This is a visualization. So the next step, going back to your question about culture, also is thinking about the ways we have these engaged physician champions, and they are involved. They're making this part of their clinical, they're making it part of their faculty work, and they're hopefully developing academic products from it. But how do we, at a lighter touch, reach more and more clinicians, and in that way pull the culture along towards one of value? So this is just an example of an automated dashboard that we have that's set up where each bar here for each one of these measures represents an individual hospitalist, with the colored bar representing the individual hospitalists that I'm impersonating in this one. And very quickly, a clinician can go in here, see their own kind of trajectory over the course of time, see their own relative performance to their colleagues. And again, what's meaningful about this is that these are all locally defined ones that were identified, validated by the lead hospitalist, and then brought to their colleagues. And this allows for culture change through sharing of data. We can also set this up initially. The hospitalists and many other specialties are showing those data to be blinded here. So these are anonymized numbers, but that can be toggled as the culture changes to share unblinded performance data.
And this is great. I mean, the slides are very clear. They look very easy to use. And I think what's also very unique about what you're doing is that you have an army of folks across the institution that are helping with some of this culture change, sharing this data, getting used to seeing data, getting audited. And I know that, that collaboration between having the data, the metrics that you trust, along with the educational interventions, as you said, and some coaching about how to improve these over time, sounds like is a great recipe for success. I know we're winding down on time, but I did want to ask you one last question, which is for other health system managers or folks that might be in a similar position as you, which I consider somewhat of a bridging role between, the health system world as well as the educational centers in the academic world, to start a program similar? What are the key pieces of advice you might have or resources that you think are really required looking back at your journey?
I think the key concept is to trust the idea that that going to your clinicians and going to the frontline practitioners is where you're going to get the richest ideas that are likely to lead to the best outcomes for your patients, but also the best acceptance from your physicians and other clinical team members. And investing in what can be a years-long program is highly worthwhile, and in many ways the only way to do this. The trick of it is how to align that internal program with what are mandatory externally reported measures, as well as participating in all the kind of necessary requirements in addition. But this really is, in our belief, in our experience now, the fundamental way to do it, and the clinicians will love it. They'll get engaged with it. There'll be an overwhelming appetite for doing this because it is the right way to do it.
Well, thank you so much, Robin, for joining us today, and for all of you joining us in the discussion. Next month, we will be having another speaker join us. And one thing to let you all know out there is that every quarter or so, we're going to be focusing on a health systems speaker. So, Robin, thank you again for representing that group.